What's up, lovely people? It's happening. It's the Endocrinology playlist. Today we'll talk about clinically oriented anatomy of these endocrine glands. We will discuss everything related to endocrinology, from the easy stuff all the way up to how to calculate the dose of insulin. Because I know what's up. You go to medical school and your anatomy professor bombards you with trivial minutiae about origin, insertion, nerve supply, and action, not to mention relations. And then you go to your physiology professor who does not listen to feedback, no pun intended. Then pathology or path, and the psychopath, your professor, convinces you that life is not pink and rosy. There is so much pain and suffering. In fact, the only pink that you're going to see is under the microscope using the hematoxylin and eosine stain. And then comes your Joe Rogan, pharmacology professor, and he wants you, makes you miserable to the point, I just want to do drugs. Don't do it. Now, I'm gonna be honest with you, anatomy sucks, but clinically oriented anatomy is so amazing. It's the best thing that ever happened since sliced bread. Because this is about stories. I'll tell you, why was Kulthum afraid of thyroid surgery? Why was the trumpeter afraid of the parotid surgery? Why do you ask the patient to swallow during thyroid exam? Why do you ask the patient to stick out his or her tongue during thyroid exam? Not to mention it's disgusting. Why did the patient started convulsing after total thyroidectomy surgery? Why are ADH and oxytocin secreted from the hypothalamus and not just from the anterior pituitary like all the others? I will use economics to teach about Sheehan postpartum necrosis, and I'll tell you should be bloody careful before you cut the splenorenal ligament. So here are the glands that we'll talk about throughout this series. You have the hypothalamus, or as I like to call it, this is the CEO. And the pituitary, which is the general manager. Of course, the CEO is higher than the general manager. Then you have the employees. You have 3 employees that obey the pituitary glands, and 3 employees that could not care less. They don't give a rip about the pituitary, let alone the hypothalamus. Why are these not listening? Okay, let me explain it to you. Adrenal medulla, when does it work? Oh, it secretes epinephrine when I'm running from a tiger. Perfect. Let's say you're running from a tiger. And let's suppose that the adrenal medulla would actually listen to the pituitary and the hypothalamus. Here is how it's gonna go down. Your hypothalamus is going to secrete hormone X, and then the hormone X is going to be secreted into the bloodstream in the hypothalamo-hypophyseal portal circulation. And then the pituitary will respond to hormone X, and the pituitary will start secreting hormone Y. It will secrete hormone Y into the bloodstream. Now it's going to take time from the bloodstream and the brain until we reach your adrenal medulla, because we have to go throughout like almost every organ in your body because the heart is pumping, and we have to wait until these drops of blood reach your adrenal medulla. By the time this happened, the tiger would have eliminated your gluteal region. All that will be left is your sphincter. These 3 glands obey the pituitary and the hypothalamus, but these 3 glands, they are still endocrine, but they do not give a rip. Let's play a game. Let's talk to the thyroid. The thyroid is gonna listen to us. It's an obedient gland. Okay, hypothalamus, please go ahead. I'll secrete something called TRH, thyrotropin releasing hormone. TRH is gonna go to the pituitary gland. The pituitary is gonna respond and secrete TSH. TSH is gonna go to my thyroid, and then my thyroid is gonna respond by secreting T4, 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 and some T3. That's why T4 is called the thyroxine, because it's the predominant hormone. Next game, let's play with the adrenal cortex. Again, it's cortex because the medulla doesn't give a hoot about the pituitary. Hypothalamus, please secrete CRH, corticotropin releasing hormone. And then CRH is going to go to the pituitary to secrete ACTH, adrenocorticotropic hormone. ACTH is going to go to the adrenal cortex. Adrenal cortex is going to respond by secreting steroids, or cortisol to be specific. Now let's understand these words. Corticotropin releasing hormone. Oh, this is the hormone that's going to release the corticotropin. So, who is the corticotropin here? The ACTH. That's the corticotropin. And why is this name so long? Because every word here has a meaning. It's the adrenocorticotropic growth hormone. It's the hormone that will make the adrenal cortex grow and blush and prosper and secrete cortisol. Beautiful. Next, gonads, the ovaries and the testicles. Hypothalamus will secrete GnRH. Go to the pituitary to secrete two things, LH and FSH, and they will go to the gonads, and the gonads are going to respond. In females, they secrete estrogen and progesterone. In males, they secrete androgens. The word estrogen, why do we call it estrogen? Because gen means genesis, and estra is the estrous cycle. Estrous cycle is the menstrual cycle in animals. Something your professor will never tell you. How about Mr. Progesterone? It's pro-gestation. Gestation is pregnancy. This is the hormone that's pro-pregnancy. It helps maintain the endometrial lining. In males, they secrete androgen, specifically testicular androgen and testosterone. Why do we call it androgen? Gen means genesis. Andro, if you have a friend whose name is Andro, the word andro means man. Androgen is the generator of manliness. Beta males and soy boys have left the chat. Now let's talk about Kulthum, also known as Suma, or Isit, or the Star of the East. Born in poverty in the Egyptian countryside, in an era where people who lived in rural areas did not see a doctor like ever. The barber was supposed to take care of their health issues. You got a cold? The barber is gonna spread some wet newspaper on your chest until you recover. Got an eye problem? The barber has some gooey substance. He will pour it into your eyes, and this gooey substance treats all ophthalmological conditions. Suffering from some chills? They're gonna put out cigarettes in your armpit. Here is a personal story. 2015. I went to visit one of the poor villages in Egypt. I've met the entire population of that village. Not a single person had eyeglasses. Now you can call me a moron, but errors of refraction are the most common pathology in the freaking world. Error of refraction is more common than anemia, for heaven's sake. In spite of all of these circumstances, Kulthum was not just blaming everybody or blaming society. She did her best. She wanted to sing for a living in an era where having a lady from the countryside of Egypt leave her parents and go to Cairo to sing was unheard of. But she did it. And then she rose like a freaking phoenix. She became the most famous singer in the history of the Arab world. You know when you go to Starbucks and they have a Spotify playlist? No, not in Egypt. If you go to any cafe in Egypt, it's always Kulthum playing there. There are many examples of people who, painfully aware of their backwardness, decided that enough was enough and that they were going to improve their lives, and some succeeded tremendously. Kulthum did it, Dr. Thomas Sowell did it, Dr. Walter Williams did it, J.C. Penney did it, Rose Blumkin did it, Oprah Winfrey did it, the two bicycle mechanics did it. I'm talking about the Wright brothers, by the way. Yeah, the people who invented the airplane, they were bicycle mechanics. So what are you waiting for? Kulthum started noticing some symptoms. Sweating, tremors. Oh, that's not good if you're singing on stage. Palpitations, weight loss, diarrhea, and increased appetite. Like weight loss in spite of increased appetite? Yes, indeed. And then came two things that she likes. Number one, her hair became more silky, and her blood lipids decreased. What's the diagnosis? Hyperthyroidism. The thyroid gland is the oven or the stove of your body. Too much thyroid hormone, too much metabolism. Everything is working like crazy. I'm sweating, increased tremor, increased palpitation. Weight loss, why? Because of increased metabolism. Diarrhea, why? Because of increased motility of the GI tract. Everything is increased, but the blood lipids are decreased. Why? Because we are increasing the rate of their breakdown. Kulthum traveled to the United States and met a famous surgeon. Hey, big boy, would you please take away this thyroid and perform thyroidectomy? The surgeon learned that she was famous, so he said, oh, I better shape up and start reading. And now let's play a game. Can you please label these structures? Let's go. Here is your ascending aorta. Here is your aortic arch, and this is the descending thoracic aorta. Don't forget that the coronary arteries come from the ascending aorta. Next, let's focus on the aortic arch. We have three branches, 1, 2, and 3. What's the name of this? In the past, we used to call it the innominate artery, or arterium innominatum. Literally, the artery with no name until we named it. It's called the brachiocephalic artery. The brachiocephalic will give you two branches, a branch for the brachium and a branch for the cephalic. This is going to be called the subclavian artery, and this will be called the common carotid artery. Subclavian will later become the axillary, and then the brachial, and then radial and ulnar. And you know the rest of the story. The common carotid will give you the external carotid and the internal carotid. This is what happened on the right side. On the left side, however, we have two separate branches. This is the left common carotid and this is the left subclavian. They had separate origins from the beginning and not a common origin like this one. What is this? It's the right vagus nerve. Why do we call it vagus? Because it's vague. It starts in your brain and it reaches your gut. We did not know its function. We called it vagus. And then the vagus will give you a recurrent laryngeal nerve. I freaking love this name because the vagus nerve was going down. And then it decided, you know what? Let's give a branch to the larynx and it's going upwards. It's taking a U-turn. It's reversing. It's a recurrent laryngeal nerve. And this is on the left side as well. You have the left vagus nerve and the left recurrent laryngeal nerve. As you see, the recurrent laryngeal nerves are in close proximity with the thyroid. So can you give me some complications of thyroidectomy? Thyroid is the thyroid gland. Ectomy is to remove something out of the body. Number 1, injury to the recurrent laryngeal nerves. Yep, and this will lead to what? Oh, these normally supply the larynx. Now the larynx is screwed. You get hoarseness of voice. You can injure the superior thyroid artery or the thyroid ema artery or inferior thyroid artery, etc., which will lead to bleeding. Superior thyroid and inferior thyroid are present in everybody. The thyroid ema artery is only present in 10% of the population. Sometimes the parathyroid glands are embedded within the substance of the thyroid gland. If you're not careful or if you're performing total thyroidectomy, you might remove the parathyroid glands. Without calcium, you get hypocalcemia. Severe hypocalcemia will lead to tetany. Tetany will lead to spasms, contractions, and even convulsions, and maybe laryngeal spasms. Oh, this is dangerous. And that's why we prefer subtotal thyroidectomy to total thyroidectomy. What's the difference? Subtotal is trying to reserve the posterior aspect of the thyroid gland to spare the parathyroid glands because they are on the posterior aspect of your thyroid gland. Let's say that the surgeon was a doofus, removed my parathyroid glands. What will happen? Low calcium. What happens when calcium is low? Calcium is contra-excitability. When calcium is low, your excitability is so high. We call this tetany. And we have the positive Trousseau sign, as we have discussed before in my playlist known as Signs in Medicine, and a positive Chavistic sign. Both mean hyperexcitability. So the surgeon got educated after reading those textbooks because he did not have WebMD back in the day, and he learned that the recurrent laryngeal nerve comes in close proximity to the thyroid gland. And then he was shocked. He remembered something, so he asked the nurse, "Hey, yo, Tiffany, what up? What was the occupation of our Egyptian patient, please?" "Oh, what? Say what?" "She's the most famous singer in the Middle East."
"Oh my goodness, and I'm about to perform a surgery that might injure her recurrent laryngeal nerve causing hoarseness of voice."
"It's not gonna happen. I mean, if I injure the nerve, they're gonna call me the Wicked Witch of the West." "I'm sorry, Tiffany. I know you wanted your commission and a $100 Amazon gift card. But guess what? I'm not gonna get paid either."
Hey, Kulthum.
"Yes, doctor."
"When I graduated medical school back in the day,
"Go straight to the point, doctor."
I took the Hippocratic Oath. I did swear to do no harm."
"I don't have time for you, doctor."
"Listen to me and you shall hear the complications that I will fear."
This surgery can have some complications. Now, these are rare, but I need to tell you about them. A. It can lead to temporary disruption of phonation because the thyroid is next to the larynx. You can suffer from laryngeal spasm. Injury to external laryngeal nerve can lead to paralysis of the cricothyroid muscle, and this will give you a monotonous voice. Or worse, injury to the recurrent laryngeal nerve will give you hoarseness of voice. Kulthum replied, "وَغَدًا أَلْقَاكَ." "See you later, doctor. I'm not doing it."
But you have sweating, tremors, and palpitations."
"You can kiss my calcaneus, lick my lateral malleolus and massage the medial one. It ain't gonna happen, baby. All of my fame and all of my career hangs around my gratitude to God, who created my recurrent laryngeal nerve. You miss with the recurrent laryngeal nerve, even if it's 1% chance. And I am toast.
Hey medicosis, let me ask you something. How come a strong, independent woman like Kulthum be afraid of some minor surgery like thyroid surgery?
Look, my friend, you are a third-party observer sitting on your gluteal region on the couch and second-guessing what other people should do with their own health. Shut up. The recurrent laryngeal nerve might not be a big deal for you, but for a world-class singer, it's everything. And while Nancy Ajram might perform 13 plastic surgeries every single day, she will not let any doofus come close to her recurrent laryngeal nerve, I'm telling you. Next, let's talk about thyroid cancer. First, the thyroid gland is larger in females than males. This is point number 1. Point number 2, the thyroid gland in females fluctuate with hormonal changes, with menstruation, and with pregnancy. On the other hand, the thyroid gland in male is as fixed as a male copulatory organ in the pre-orgasmic phase. And here is the 64,000 question. Do you think thyroid cancer is gonna be more common in females or males?
I don't know. Haven't studied endocrine pathology yet.
Okay, so you have an amoeba for a brain. Let me ask you a simpler question. On average, the female breast is larger and more functioning than the male breast. Do you think breast cancer is more common in females or males?
Oh, of course it's more common than females.
Then by the same token, doofus, thyroid cancer is more common in females. And thyroid disease in general. Let me tell you something. My dad is a pathologist and he gave me a great tip. He said, son, listen to me and you shall hear. And get your head out of your rear. All cancers are more common in males except thyroid cancer and gallbladder-related cancer. And of course, it goes without saying, endometrial cancer, ovarian cancer, and all of the cancers related to the female genital tract. Other than those few exceptions, every single stinking cancer is going to be more common in males than females. You name it. Colon cancer, more common in males. Skin cancer, more common in males.
Hepatocellular carcinoma,
Males. Lung cancer, males. This fact is going to save you hours in studying. So what is cancer? That's not an existential question. We have talked before about types of cellular growth. We have hypertrophy,
increase the size of the cell.
hyperplasia, increase the number of cells. Metaplasia, when you change one type of cell to another type of cell within the same category. Epithelium to another epithelium. Or connective tissue to another connective tissue. You cannot jump from epithelium to connective tissue. Get your head out of your sphincter.
Dysplasia, what does this mean? Difficulty, plasia, growth, difficulty growing.
Yep, you are that close from neoplasia. Neoplasia, this is the one that contains benign tumors.
No big deal.
Malignant tumors, those are the cancers, and those are nasty. But of course, every cancer is different. So, tumor is the same thing as neoplasia, is the same thing as any word that ends in oma. Lipoma, melanoma, hepatoma, adenoma, adenocarcinoma, you name it. Next, we divide tumors into benign or malignant. And then the malignant are carcinomas or sarcomas. What's the difference? Carcinoma arises from and is made of epithelium. Sarcoma, connective tissue. And then when they metastasize, carcinoma will go to the lymph, but sarcomas prefer blood. And this is called cancer predilection. Now let's apply this to thyroid cancer. Do you think thyroid cancer is going to be a carcinoma or a sarcoma?
I've no idea. I've never studied endocrine pathology before.
Shut up. Try to think. What's the name of the thing?
Thyroid gland.
Can you say it one more time? Thyroid gland. You said gland? Yeah. When you have a gland, what kind of cells are these? Do you think they are epithelium or connective tissue? Oh, of course they are epithelium.
Yeah, because connective tissue does not secrete, doofus.
That's an epithelium.
You think it's a carcinoma or a sarcoma?
Since it's made of epithelium, it's going to be a carcinoma. Perfect. Where does it drain? It's going to drain into the lymph. Excellent. What kind of lymph node?
Oh, I don't know.
Pay attention. Here is your neck, right? Thyroid is in your neck. That's true. Therefore what? Almost every structure in your head or in your neck eventually end up in the deep cervical lymph node. I rest my case. Medicine makes so much sense once you understand what the flip you're talking about. Here is a question for you. When I say pituitary adenoma, do you think this is benign or malignant?
I don't know, I've never studied endocrine pathology.
Shut up and try to think. Dadgummit. We have two words, adenoma and adenocarcinoma. Which one do you think is malignant? Oh, the one that has carcinoma in it. Excellent. Therefore, adenoma is always benign. Adenoma, always benign. Adenocarcinoma, always malignant. Lipoma, always benign. Liposarcoma, always malignant. Myoma, benign. Myosarcoma, malignant. Next, let's say that a gland is hypersecreting. Your pituitary is secreting lots of stuff. What is the pathology? You have only three choices. It's either hyperplasia, adenoma, or adenocarcinoma. That's it. Let's say that the zona glomerulosa of your adrenal cortex is hypersecreting. What are your probabilities? It's either hyperplasia, adenoma, or adenocarcinoma. And most of the time, it's either a hyperplasia or an adenoma. Adenocarcinoma is not that common when it comes to cases of hypersecretion. How about the gland that is hyposecreting? It means there is atrophy. Now, what is causing the atrophy? It could be crowding out. Let's say that this is your adrenal cortex. It has 3 layers. Let's say that we had an adenoma in this layer. Oh, now the adenoma is going to grow and grow and grow and grow and crowd out the cell in the next layer. Oh, this is called atrophy. So you have hyperplasia here, or you have neoplasia here, but atrophy here. And this is called pressure atrophy. Another possibility is something nasty causing this atrophy. Example, tuberculosis going all over your blood. Especially the secondary tuberculosis. It can lead to destruction of the entire adrenal gland. Or let's say you had cancer metastasis. So there is cancer somewhere else and it's metastasizing to the adrenal. It's going to destroy everything, causing atrophy, causing hyposecretion. Or let's say you have an autoimmune disease. Example, Addison syndrome or Addison disease. You have nasty autoantibodies destroying your own adrenal gland. So now we have answered why was Kulthum afraid of thyroid surgery. Now, why was the trumpeter afraid of parotid surgery? During my lovely childhood, my favorite cartoon ever was Detective Conan. It is the best cartoon, hands down. And one of the lovely things about Conan is that he can guess the occupation of the person he's interacting with just by looking at them or just by shaking their hands. Let's say a tennis player. Oh, a tennis player is always holding a racket. Therefore, you'll find the thenar eminence and the hypothenar eminence having some protrusions and some hardening and some stuff. And the tennis player is going to be different from the ping pong player because the racket is different from the paddle. One is larger, one is smaller. You get the point. Now, let's say that you have a group of doctors sitting together. How can you spot a gynecologist? Let me tell you, all of the doctors will be drinking chocolate milk, but the gynecologist will be sipping on chocolate cyst. How to spot a dermatologist? She's sitting in the shades. A rheumatologist does not drink beer because of gout. How about a microbiologist wearing pink and purple? A pathologist complaining to the waiter about the insufficient sample. What about a radiologist? Cannot decide what to eat.
Well, as I see this X-ray, it could be a pneumonia, it could be pleural effusion, it could be pneumothorax, hemothorax, chylothorax, could be mesothelioma, could be lung cancer, could be idiopathic, or could be a freaking artifact.
That was dadgum insightful. How to spot a gastroenterologist looking inside the hole of the plastic straw. How about an andrologist? He's drinking a Viagra Chino. A surgeon. He's wearing a long pair of boxers. How about a freaking dentist? Rubbing one out. I mean the lidocaine. Back to the trumpeter. How can you spot a trumpeter on physical exam? Oh, the buccinator is absolutely ruined. It has been abused throughout the years. But why was the trumpeter afraid of the parotid surgery? Because the facial nerve, which supplies the buccinator muscle, runs through the parotid gland. So, of course, if we injure this nerve during surgery, oh my goodness, he's not gonna be able to blow. And please do not forget that the facial nerve runs through the tissue of the parotid gland, but the facial nerve does not supply the parotid gland. Who supplies the parotid gland? The glossopharyngeal. Number 9. Let's turn our attention into parathyroid glands. Parathyroid, parallel to the thyroid, next to the thyroid. Here's your thyroid gland, beautiful. Behind it, on the posterior aspect, you find 4 glands attached to the back of the thyroid. And these glands are the parathyroid glands. We have 2 pairs. The upper is called superior, and the lower is known as inferior parathyroid glands. Okay, let's say that the patient has parathyroid adenoma. We should remove it. Yeah, that's an easy task, right? And not always. What's the problem? The location of the superior parathyroid gland is easy. It's predictable, it's always here. But the location of the inferior pair is variable. You can find it attached to the posterior aspect. You can find them embedded within the tissue of the thyroid. You can even find them outside the thyroid, like not even related to it at all. The poor surgeon have to keep looking throughout the area. Where the flip are these parathyroid glands? But why is the location of the inferior parathyroid glands variable? Let me take you back to embryology. Remember the third pharyngeal pouch? Vaguely. It gave rise to the thymus and the inferior parathyroid. The inferior parathyroid started up here and descended downward like here. They are following the thymus. Normally, these inferior parathyroid glands should just keep descending until they get stuck here in the thyroid. But sometimes they just continue downwards. And while we are at it, remember DeJour syndrome has a problem in the third pharyngeal pouch. That's why the patient has no thymus and no parathyroid glands. The patient will be immunodeficient, especially T lymphocytes, and the patient will have hypocalcemia and maybe tetany. Next, adrenal cortex. We have a cortex on the outside and we have a medulla in the core. Medulla literally means core. Perfect. The cortex is not just one layer. We have 3 layers. And the mnemonic is GFR, granulosa fasciculata reticularis. If the cortex is hypersecreting, it's usually coming from one layer only. It's either the granulosa has gone crazy, hypersecreting aldosterone, or the fasciculata has gone insane, hypersecreting cortisol, or the reticularis has lost its cool and secreting too much adrenal androgens. So with hypersecretion, the problem is in one layer. What kind of problem? It could be hyperplasia, adenoma, or adenocarcinoma. But if it's hyposecretion, it's usually affecting the entire gland or the 3 layers. Like why? Because look at the cause, tuberculosis. Do you think the nasty bacteria called Mycobacterium tuberculosis cares? No, they're floating through the bloodstream and they're gonna destroy everything. Autoantibodies in Addison disease. Do you think they give a rip? No, these are systemic antibodies floating throughout the circulation. They will destroy everything. How about metastatic cancer coming from somewhere else? It's gonna destroy everything. Next, adrenal medulla, not cortex. Please go watch my physiology lectures on the autonomic nervous system. Here is the song in the adrenal medulla. Phenylalanine, tyrosine, dopa, dopamine, norepinephrine, epinephrine. Phenylalanine, tyrosine, dopa, dopamine, or adrenaline. Pheochromocytoma, what the flip is this? This is a tumor, a neoplasia of the adrenal medulla. It's hypersecreting, secreting tons of epinephrine and norepinephrine and sometimes dopamine. The end products of these compounds are VMA, and HVA. These are the metabolites. So you'll find these high in the serum and these high in the serum and the urine. In cases of pheochromocytoma, what are the symptoms when you have tons of epi and norepi? Oh, pressure is high, palpitations are high, perspiration or sweating, pain, which is headache, and pallor, the 5 P's. And it comes in paroxysms, attacks. The patient does not have hypertension 24/7. No. The patient is fine most of the time, but it comes the attack of high blood pressure, palpitations, sweating, pain, and pallor. It's a horrible attack. And then the patient is perfectly fine. And that's why many doctors miss it, because they are doofuses.
Oh, hi patient, I think you might should decrease your salt intake.
Kiss my calcaneus. Pheochromocytoma surgery. You should start by giving alpha blocker, before the beta blocker, and then you do surgery. In this order.
Oh, what if I do surgery without doing this?
Okay, during surgery, you will touch the gland, right?
Yeah.
And when you touch the adrenal medulla, it's going to secrete what? It's going to secrete epinephrine or epinephrine. Oh, and the patient has pheochromocytoma, you will worsen the situation, you doofus. Epinephrine or epinephrine will make the heart go crazy. So what should I do? Block the beta-1 receptors in the heart by adding a beta blocker such as propranolol. Oh, now I get it. And what else? When you have lots of epinephrine and norepinephrine, they can make your blood vessel go crazy in constriction. So all of this constriction will lead to increased blood pressure. So block the alpha-1 receptors in the vessel by giving alpha blocker such as phenoxybenzamine. So the disease is Pheochromocytoma and the drug is phenoxybenzamine. Everyone has 16 letters.
Okay, I get it, but why should I give alpha blocker before the beta blockers? What if I give the beta blockers before the alpha blockers?
Okay, let's give the beta blockers first. So you have blocked the receptors on the heart, so now the heart is not gonna go crazy. Awesome. But now all of the epinephrine will go to the vessels, acting on the alpha-1 receptors, making the vessel super tight and the blood pressure super high. The super high blood pressure can kill the patient, or the reflex bradycardia can kill the patient. So you need to do this in this order. Let's talk about the pituitary gland, the general manager, and Sheehan syndrome or Sheehan postpartum necrosis. Let's start by economics. Remember supply and demand? Oh yeah, during pregnancy, mommy is in demand. Yeah, these ovaries need to secrete tons of estrogen and progesterone, and therefore the pituitary needs to grow bigger. And therefore, its blood supply needs to increase to accommodate the increased demand. So normally, before pregnancy, everything here is at equilibrium. You have the supply curve. Supply with an S goes to the sky, but the demand curve with a D goes to the dirt. And this is the doozy point of equilibrium. As long as we maintain the equilibrium here, we're cool. Now, mommy got pregnant and we want to secrete tons of estrogen and progesterone. We have increased demand, so we have shifted the demand curve to the right. Okay, now look at what happened to the equilibrium. We used to be here, but now we are here. This is disequilibrium, so we're gonna adapt. We want to increase supply, shift to the right. What do you mean by increase supply? I mean increase the size of the pituitary gland and increase the blood supply to the pituitary gland. Now when we shift the supply curve, oh, look at the point. Now we are back to the level of equilibrium. We're not here anymore. We're back to equilibrium. Awesome. Everything will stay hunky-dory. But if mommy loses a lot of blood after delivery, known as postpartum hemorrhage, what's going to happen? Now you have a big pituitary with no blood supply because all of the blood has been lost. The pituitary is going to be crying for oxygen and it's going to shut down.
So why do I care?
Of course you should care because the pituitary secretes ACTH, TSH, and prolactin. Now mommy is not going to notice the TSH and ACTH decrease, but she will notice the decreased prolactin. How come? Mommy will not be able to lactate. Mommy will not be able to breastfeed the baby. And that's why we call it prolactin, prolactation. So if you want to be a good doctor, whenever you see a lady failing to lactate after delivery, you should think of Sheehan syndrome. It's not the only cause, but it should pop into your mind. Always assume the worst first. Rule out the disasters and then go to the minor stuff. Next, your pancreas. Your pancreas is a great exocrine organ and an endocrine organ. If you secrete secretions into ducts, and the ducts will take into the GI tract, that's exocrine. But if you secrete secretions directly into the bloodstream, that's gonna take me places all over the body, that's called endocrine. Here's the pancreas, right? Yeah, you have head, and you have uncinate process, you have body, and you have tail. Awesome. On top of the pancreas, you see two vessels running smoothly, the splenic artery and the splenic vein. Encasing all of these structures is something called the spleno-renal ligament. The old name is the lano-renal ligament. A doofus surgeon will cut this ligament. Oh, let me just cut this ligament. Let me tell you what's going to happen. Now you have cut the splenic artery and the splenic vein. Tons of blood. Lots of bleeding. You have cut the tail of the pancreas. What does the pancreas contain? Oh, digestive enzymes. Yes, the pancreas is capable of completing the digestive process from A to Z. The pancreas can digest proteins, fat, and carbohydrate. And when the patient's abdomen is open, what do you see?
I see peritoneum. Oh, I see ligaments. Oh, there is tons of fat, proteins, and carbohydrate.
Yes, and when you cut the tail of the pancreas like a doofus, everything will be digested in front of your eyes. The patient's insides will be melting. You will probably end up behind bars and the patient's family will kick your butt. We have a year-end sale. Get a 50% discount towards everything on my website. Just use the promo code HALF at medicosisperfectionalis.com. If you want more clinically oriented anatomy, check out my pulmonology playlist on YouTube. We had clinically oriented anatomy of the thorax. It was one of my most liked videos. Happy New Year, everybody. Thank you for watching. Please subscribe, hit the bell, and click on the join button. You can support me here or here. Go to my website to download my cardiac pharmacology course, my antibiotics course, and my CNS pharmacology course, among others. Use promo code HALF to get 50% discount. Thank you for watching. As always, be safe, stay happy, study hard. This is Medicosis Perfectionalis, where medicine makes perfect sense.